Hi everyone, this is Mr Neel Raithatha, also known as the Wax Whisperer. Thank you for tuning in to my latest video. So the patient who attended with bilateral fully occluding dry wax and dead keratin. The patient has got very narrow ear canals, and we're just starting off in the left ear here. And this occlusion, so this blockage of dead skin wax, extends all the way from the entrance where we are now. And we know we're at the entrance because of all the cilia, all the hair strands. The outer third of the ear canal, the cartilaginous portion, is the part of the ear canal that bears all the hair follicles. The hair follicles, which from where the hair strands originate from, serve a purpose. Attached to the hair follicles deep at the root of the hair strands are two glands. The first gland is the sebaceous gland, which secretes an oily, lipid, fatty secretion called sebum, and sebum is the same oily secretion we find on our scalp due to our hair on the scalp. And there's a second gland that is, for some people, attached to the hair follicles, which is the ceruminous gland, which is an oily sweat gland. And these glands that are attached to the hair follicles then secrete the sebum and the oily sweat, which then is transported up the hair follicle, up the hair strand to the ear canal itself. And these two secretions, along with dead skin, form earwax. The hair strands also are used to filtrate air, so any foreign particles, dust, dirt, pollen, they're designed to filtrate that. Similarly to our nose at the entrance, we've got a few hairs there. I'm just using a combination of microsuction and in a moment some crocodile forceps to remove this. Now you can see the ear canal is really, really narrow. The diameter of the Zollner suction probe, which is what I'm using at the moment, it's more or less the same diameter of the ear canal. I can just about safely insert the Zollner suction probe into the ear canal. There's not much other space available within the ear canal other than for the Zollner suction probe. I'm just trying to gently bring this dead skin, keratin and wax to the entrance. When you've got a small narrow ear like this with a lot of dead keratin, sometimes we do get a bit of reflection from the eye clear scope. We can turn down the brightness, but it wasn't really affecting me, so I was just continuing. And I'm just slowly but surely tugging this dead skin forwards. And the way we tug, I sometimes go around in little circles. So by going around in little circles with the Zollner suction probe, we're just detaching this dead skin off the canal wall. And sometimes I go up and down like I am now, just to really, really tug and loosen away this dead skin off the canal wall. So the more lateral part of the occlusion was dead skin. This is a bit more wax that we're removing now. Excuse me, I just felt I needed to sneeze there. So I'm just getting a suction grip. Now, this plug is probably slightly larger than the entrance of the ear canal, hence why it's not coming out in a straightforward manner. So we're having to almost squeeze this plug through. And I think at this stage I'm going to revert to the forceps. We've got a good grip. You can see the jaws of the forceps that have engulfed itself around this plug, and you can see the size of this plug. It is actually larger than the entrance, but with the force of the forceps we can bring this forwards. That's the patient's eardrum, nice and healthy. The hammer bone, there's some vascularis, so the blood vessels that are attached to the hammer bone are slightly dilated, so we call that vascularis. There's a lot of blood flow there, most likely because this plug was in contact with the eardrum. So just on the right here again, the patient's ear canal is very narrow, especially at the entrance. I went in with the forceps immediately, and I did manage to pull out a strand of dead keratin or ribbon. And there's some more dead skin that I managed to remove. And again, once more, you can see all the hair strands. So whenever you see the hair strands, when you see a procedure in the ear, you know we're on the outer third, the cartilaginous portion. The inner 2/3 of the ear canal, coincidentally, there's no hair strands, it's just a thin layer of skin directly on bone. And similarly to the left side, the obstruction near the entrance is more dead skin. As we go further into the ear, it's a bit more dead skin and wax. And a good clue is that when you've got a lot of keratin in the ear, you have a glossy appearance of the wax. So as I mentioned earlier, there's 3 ingredients to earwax. You've got the sebum, which is the oily, fatty secretion that we find on our scalp. You have the oily sweat, secreted by the ceremunous glands, and dead skin. So earwax is actually made up of dead skin. In this case, there's a higher composition of dead skin. Approximately 60% of earwax in normal earwax is made up of dead skin, and the other 40% is a combination of sebum and oily sweat. In this case, this part of earwax I'm removing now, it's got a higher composition of dead skin. I'd probably say between 70 to 90% of dead skin. Whenever you've got a lot of dead skin or high composition of dead skin within earwax, you get this glossy appearance where you get a reflection. So just using the forceps once more. Again, you can just see how narrow this ear canal is. I can just about insert the forceps into the entrance. You can see a big plug of wax and skin was just removed there. But that's the patient's eardrum. There's no vascularis of the hammer bone there, so the blood vessels are not dilated. And just a close-up video of all the debris I removed from the ear, which is quite a lot considering how narrow their ears were. And they notice a significant improvement in their hearing. I hope you're all keeping well, guys. Take care.